My name is Eduarda Gusmao. I'm the country director for ICAP Mozambique. I'm going to present our work with the Minister of Health to support the rollout of pediatric Dolutegravir in Nampula province. Mozambique has a generalized HIV epidemic with a prevalence of 12.5 in 2021. In 2022, we saw an estimated 13,000 new pediatric infections with about 150,000 children living with HIV in country. While we see a sustained increase in pediatric ART coverage, with the national coverage at 84% by June 2022, challenges with access to most effective and child-friendly formulation was still a challenge. Initial introduction of pediatric treatment optimization in country used lopinavir-based formulations, and challenges with palatability of those formulations impacted treatment outcomes among children. Viral suppression among children living with HIV less than 5 years of age was still at 68% by December 2021. So when the Minister of Health implemented pediatric Dolutegravir in February 2022, we worked closely with them to support an effective and rapid rollout. We looked into data from all health facilities in Nampula province where ICAP works to identify the number of children currently receiving lopinavir-based regimen, to estimate the number who would be eligible to transition to Dolutegravir. We also looked into the average number of new initiations among children on lopinavir-based regimens to estimate the anticipated number of new pediatric Dolutegravir initiations. With that information, we worked with the Minister of Health and Central Warehouse to design the provincial supply and distribution plan, as well as at the provincial level to design the health facility distribution plan. At health facility level, at provincial level, ICAP implemented an intensive monitoring strategy to ensure rapid rollout. We had weekly monitoring using a very simple Excel table designed by ICAP team that was to be completed weekly by health facilities teams. This table, as you can see in the slide, was allowed us to monitor and report pediatric transition at all supported health facilities. It was located at a shared drive and available to teams at health facility, provincial, and central level. At health facility level, teams would review files of children with a scheduled visit for the following week, as well as children who came every day without a scheduled visit. All children identified as eligible for transition to Dolutegravir had their clinical files flagged to remind clinicians to transition and were included in a daily tracker. At the end of each day, health facilities teams would review each individual file of a child with a clinical visit, and all the total number of children who transition or newly initiated Dolutegravir were also included into the daily tracker. At the end of the week, the teams would summarize and compile the information, and including the online tool, including the number of the eligible children living with HIV, how many of those attend a clinical visit, and how many of those who came for a clinical visit transition or newly initiated Dolutegravir. ICAP teams reviewed that data weekly, and for all sites where we identified missed opportunities, immediate feedback and targeted support was provided. In addition to the weekly monitoring, we also worked with the provincial health leadership to implement a monthly monitoring where we looked into monthly pharmacy reports for different pediatric formulations and regimens consumption. That information was included into a longitudinal tool to track monthly consumption by health facility. We review monthly the progression at the provincial level as well as the health facility level. And every health facility with persistent high number of children still on lopinavir-based regimen received immediate follow-up as well as targeted potential visits and phone calls. This information was also triangulated with health facility stocks to identify gaps and support supply chains if needed. This graph shows the proportion of children in the different pediatric ERT regimens by month. The blue represents lopinavir-based regimens. The yellow represents dolutegravir 50 milligram based regimens, and the green dolutegravir 10 milligrams based regimens. As you can see, pediatric dolutegravir was introduced in February 2022. And within a month, more than half of the children had already transitioned to pediatric dolutegravir. And within 3 months, all children were receiving dolutegravir-based regimens. In addition to the intensive monitoring at the beginning of the implementation, ICAP also provided support to enhance adherence and treatment literacy. Pediatric ERV flip chart was developed with the Ministry of Health to support providers, provide support, counseling support for caregivers. Peers and clinical staff were trained on the use of this tool, as well as key messaging. And this tool was used during clinical visits, psychosocial support visit, waiting area activities, and during home visits. Also, in addition to that, peers would align their time of their visit, their home visits, with the medication intake to provide directly observed therapy for children during their home visits. ICAP also designed and implemented a master caregiver support group that targeted caregivers of children newly initiating ERT or with an unsuppressed viral load. During the support groups, peers and lay staff would provide practical demonstration of medication preparation and delivery, peer support, sharing challenges, fears, as well as successful strategies. Caregivers who graduated, which means their children had a suppressed viral load, became mentors and co-facilitated meetings. This graph shows the result of viral suppression. You can look into this graph is split by age bands, but also each bar represents 1 quarter. So you can see here viral suppression among children who collected a viral load during the reporting period. I will focus on the first 2 set of bars. If you can look, the blue bar represents the period between October and December 2021, which is considered the baseline as it's right before pediatric dolutegravir introduction. As you can see, both for children below 1 year of age, the first set of bars, and children 1 to 4 years of age, the second set of bars, we moved from 66 and 68% respectively prior to dolutegravir introduction to close to 90% in both groups a year after pediatric dolutegravir introduction. So preparedness and planning, including the use of existing and routine data to inform national and subnational forecasts and distribution, was essential to ensure existence of stock and allowing uninterrupted rollout of pediatric dolutegravir. Targeted and close monitoring with the design and implementation of a very simple tool to monitor the process, provide support for supply chain and timely feedback to address clinical follow-up gaps, enable very rapid transition to dolutegravir with all children transitioning over the course of 3 months. And the rapid transition associated with enhanced adherence support strategy allowed for the achievement of viral suppression rates close to 90% among children less than 5 years of age within a year of implementation of pediatric dolutegravir. This was what I wanted to present. Thank you very much.